Good morning. Welcome to the second day of GIEQs 3. Today we focus on endoscopic ultrasound, and we start, of course, with the training in biliopancreatic endoscopic ultrasounds. I have a whole panel with me. I'm very glad they are here because they all trained me. So we have Professor Pieter Hindriks, who is my colleague here in the University Hospital in Ghent. We have Dr. Christophe Snauwaard, who works in Sint-Jan in Brugge. And we have Dr. Edgen Sesmeli, who works in St. Lucas in Ghent. We also have a live case with Professor IJzendraat and Dr. Marlies Mali, who will come to later. So we will start with the training. This is based on the position statement of the ESGE guidelines, who were published in 2021. So first, they state for training in general that there are pre-adoption requirements to start the training, and that is that every endoscopist should have a competence in upper GI endoscopy before they can start training in endoscopic ultrasound. And this is stated that it should be at least 300 gastroscopies. Next, they provide a training and learning steps in endoscopic ultrasound. And they state that when available, trainees should start their training by undertaking structured supervised endoscopic ultrasound simulator-based training. So I don't know if there is any experience in the room with simulation-based training, and if you were happy that you could do that.
Well, there are some models to train punctures and also therapeutic steps. I think that this is a good way to use simulation-based training, but for a diagnostic EUS, I think it's difficult.
Yeah, indeed. For the punctions and for how to release LAMS or hot axials, it's of course very useful that you don't have to do it for the first time in a patient. Okay. So these is the proposed steps in training in endoscopic ultrasound. So they first say that, of course, in-room observation is the first big step. And then after virtual reality and mechanical simulators, they state that you can start with basic diagnostic echoendoscopy. Then again, you should do simulators for more advanced procedures, for example, the LAMS, to release a LAMS, that you can then move to hands-on in therapeutic echoendoscopy. And then even after all these steps, that there is still some need to maintain competence in low-volume procedures. Is this something you can support, or...?
Yeah, I think it's important that you are trained in upper GI endoscopy, and maybe also in to handle a duodenoscope, because the EUS scopes are quite similar in the handling, especially in the duodenum as compared to duodenoscope. I don't know if you agree. Yeah.
Also to be sure that you also can evaluate the papilla region.
Yes.
Because if you're just trained in doing the normal diagnostic gastroscopy, you can't really see handle a duodenoscope. So I think you're right.
Okay.
And you also
yes,
used it in the
yeah. Later on, I used the book by one of the bestsellers. I think was by Rob House and Paul Fokkens.
Yeah.
So that way you had a lot of images, because I think in the learning curve it's important to see a lot of images.
Yes.
So that you can form your own internal atlas of what to expect when you perform EUS, and also a low treasure. How do you say it? In some training sessions, in demonstrations, like in Amsterdam, they always review the different steps. Where do you start, and how do you proceed from that? So it was not only for the advanced endoscopists, but also for the ones who started. And I learned a lot from those low threshold learning experiences. For the trainees, do you agree that it's important that you let you guide by the vessels, so you don't always see the parenchyma very well, that you really need the splenic artery and vein?
Yes,
you need
again,
them.
I totally agree, but that's why I will show you I will show her the other option, which is, to my point of view, some way to identify the pancreas for sure, exactly as you say, by using a vascular axis, but in that way,
Lise is doing it very well, but
Yeah.
also it's important to not make very big movements, I think. She's making very small movements and not... Yeah, it's very nice.
Excellent comment. You're perfectly right. Often we have some pupils, some trainees, which are a bit like doing the colonoscopic movement, even if we have also to be gentle in colonoscopic procedure. But we have maybe more ample movement able. And we have, when you are doing EUS, to masterize our movement and making it more gentle.
It's also useful when you record cases because
I have a whole panel with me. I'm very glad they are here because they all trained me. So we have Professor Pieter Hendricks, who is my colleague here in the University Hospital in Ghent. We have Dr. Christophe Snauwaard, who works in Sint-Jan in Brugge. And we have Dr. Edgen Sesmeli, who works in St. Lucas in Ghent. We also have a live case with Professor IJzendraat and Dr. Marlies Mali, who will come to later. But first we will start with the objectives of this session. And it's of course to describe the various stations that you can see while doing biliopancreatic